Dr. Len Calabrese from the R.J. Fasenmyer Center at the Cleveland Clinic. I'm a professor of medicine at the Cleveland Clinic Lerner College of Medicine, and I'm welcoming you to eJournal Club. This week we have a really interesting article entitled High Frequency of Anti-Drug Antibodies and Association of Random Drug Levels with Efficacy in Certolizumab Pegol treated patients with rheumatoid arthritis. The citation from the Annals of Rheumatic Disease is on the slides, and I'm very pleased to welcome the first author of this paper, Dr. Meghna Jani, who is an NIHR clinical lecturer based at the University of Manchester in the UK. She's a very interesting young investigator. Her interests are immunogenicity to biologic agents and pharmacoepi in general. So, Meghna, welcome to our presentation.
Brilliant. Well, first of all, thank you so much for having me, and I'm delighted to be able to present this work on behalf of our group. So to start with a little bit of background on the subject, so we know that anti-TNF agents fail to control disease activity in approximately 40% of rheumatoid arthritis patients, either due to primary or secondary non-response. And over the last few years, anti-drug antibodies and low drug levels have been found to be promising biomarkers of treatment response, especially in studies that have utilized adalimumab and infliximab. So immunogenicity, or the development of anti-drug antibodies, is the ability of any foreign substance to provoke or induce a specific immune response. And in terms of biopharmaceuticals, there are a number of factors that this is dependent on. So these can be drug-related factors during the manufacturing process, for example, the amount of murine components in a biopharmaceutical, the process of glycosylation itself. There are many examples in which contaminants and process-related impurities have been implicated in immunogenicity. In terms of individual characteristics, patients with impaired immune systems, such as cancer patients, are less likely to develop anti-drug antibodies. And other characteristics may be the patient's genetic predisposition, which is a relatively unexplored factor in this area, and also the type of autoimmune disease itself. From a clinician's perspective, the factors they may have direct control over include the treatment-related factors, such as the use of concomitant therapies, for example, methotrexate. The detection of anti-drug antibodies itself may be dependent on the type of assay that's used for detection. So, for instance, using an ELISA versus a more drug-sensitive assay, such as a radioimmunoassay, for instance, and also the timing of when the sample is collected in relation to it being given. So we've previously published some work using random drug levels, which were felt to be much more practical to obtain in a clinical setting. And what we found is over 12 months, anti-drug antibodies were detected in 24.8% of patients on adalimumab, so almost a quarter of all treated patients. The key points, however, were that patients who developed anti-drug antibodies were on lower baseline methotrexate dose and had a higher disease duration compared to patients who did not. But importantly, of the two tests, adalimumab drug level was by far the one that was significantly associated with treatment response across all time points over 12 months after full adjustment. And in addition to anti-drug antibodies, low drug levels were also associated with poor self-reported adherence and also a high BMI of more than or equal to 30. So what do we know about certolizumab? Well, certolizumab, as you know, is a pegylated Fab fragment of a recombinant humanized antibody directed against TNF. And whilst the process of pegylation itself has been shown to both reduce anti-drug antibodies in some proteins, it may increase it in others. When we look at randomized controlled trials using certolizumab in rheumatic diseases, typically a low immunogenicity rate is quoted between 5 and 6%, and these have not been shown to have an impact on clinical outcomes. So the methods of how these antibodies, however, are detected is not always clear in the paper and is usually performed using an ELISA. So to date, there have been no prospective data on clinical utility of measuring certolizumab drug levels or anti-drug antibodies in any disease that it's licensed for. So therefore, the overall objectives of this study were to evaluate the incidence of anti-drug antibodies in certolizumab-initiated rheumatoid arthritis patients using robust detection techniques, to test the association between random certolizumab drug levels, anti-drug antibodies, and treatment response over 12 months, and to additionally examine longitudinal clinical factors which may be associated with both anti-drug antibodies and certolizumab drug levels. So in order to do this, we used patients from the BRAGS cohort, and this is essentially a prospective observational national cohort of UK patients about to be started on a biologic and followed up over regular time intervals over 12 months. So in order for patients to be eligible for entry, they need to meet the 1987 ACR classification criteria. They need to have active disease as defined by a DAS score of more than or equal to 5.1, despite adequate trials of at least 2 non-biologic DMARDs. And for this study, patients who are about to be commenced on certolizumab only were selected. So serum samples and disease activity scores are collected at 3, 6, and 12 months. At each time point, we measured anti-drug antibodies using a radioimmunoassay by Sanquin in the Netherlands, who have done a lot of work around this area. And drug levels were measured using a sandwich ELISA, and our primary outcome for this study was EULAR response at 12 months. So to analyze the data, we used descriptive statistics for between-group comparisons. We used ordinal logistic regression, which was used to test the association between 12-month EULAR response, drug levels, as well as anti-drug antibodies. We used a form of longitudinal modeling called generalized estimating equation with identity link for continuous outcomes to examine the effects of various covariates on certolizumab drug and anti-drug antibody levels at 3, 6, and 12 months. So these are the results. So the baseline characteristics of our cohort represent a typical rheumatoid arthritis population in the UK. They had a mean age of 58 years. 78% of patients were female, with a mean baseline DAS score of 5.9, reflecting the eligibility criteria for biologics in the UK. 81% of our patients were on a concomitant DMARD, of which 53.5% were on methotrexate. A minority of patients, so only 9 patients in the total cohort, were on a prior biologic. So in terms of anti-drug antibody formation over the 12 months of treatment, we found that 37.5% of all patients had anti-drug antibodies detected to certolizumab. And the presence of anti-drug antibodies was significantly associated with lower certolizumab levels longitudinally over 12 months, but these were not independently associated with 12-month EULAR response. So when we compared the baseline clinical characteristics of patients who develop anti-drug antibodies compared to patients who did not, the only significant factor was the number of swollen joints, which was higher in patients who developed anti-drug antibodies. And interestingly, in this study, the methotrexate use or dose was not significantly different between the two groups. In the next slide, we see that we went on to test the association between certolizumab drug levels, anti-drug antibodies, and 12-month EULAR response. And we find that certolizumab anti-drug antibody status is not significantly associated with EULAR response independently. So you can see that the confidence intervals cross 0. Certolizumab drug level, however, was significantly associated with 12-month EULAR response. So ideally, well, this is all well and good, but we want to use these drug levels to potentially tailor treatment in the future, and therefore it would be useful to identify a key threshold to optimize treatment response if that's possible. So in order to do this, we generated something called a concentration effect curve at 6 months with change in DAS on the y-axis and drug level thresholds on the x-axis. And in this study, we see a threshold of between 24 and 29 micrograms per mil appears to be the optimal threshold in obtaining an adequate delta DAS score at 6 months. And any higher than that doesn't seem to achieve any greater benefit. And so on the next slide, you can see that in addition, the graph that we see here demonstrates the certolizumab levels in EULAR good, moderate, and non-responders at 12 months. So what we see on the right of this graph is that patients with the highest certolizumab levels appear to have the highest proportion of good EULAR responders. The patients with certolizumab levels, on the other hand, of less than 10 micrograms per mil have the higher proportion of no EULAR responders at 12 months. So we determined that in terms of pharmacological biomarkers, drug levels are the more important of the two. However, we were interested in what longitudinal factors may be associated with each. So for anti-drug antibodies to certolizumab, the only significant factor associated with these was, at over 12 months, was the certolizumab drug level. And methotrexate dose or use, CRP, ESR, BMI, and age did not have a significant impact. When we assess predictors of drug levels in certolizumab-treated patients over 12 months, in the univariate analysis, we find that female gender, BMI, CRP, ESR adherence, and anti-drug antibodies were all significantly associated. However, in the multivariate model, after full adjustment, we only find that two factors remain significant, and these are the anti-drug antibody level and the adherence status, so whether or not the patient is indeed taking the drug, the latter being an important clinical take-home message, we think. So to summarize, we found that anti-drug antibodies were detected in 37% of patients treated with certolizumab, which is much higher than previous estimates from randomized controlled trials or elsewhere. And what this may mean is that even small non-glycosylated fragments can be immunogenic, but also that certolizumab is a fragment, and therefore the drug-anti-drug antibody complex may dissociate more easily, and therefore one may be more likely to detect them. Importantly, we found that certolizumab drug levels are associated with 12-month EULAR response in rheumatoid arthritis, and of the two factors, the two factors significantly associated with these across all time points was the detection of anti-drug antibodies and patient adherence, and the latter being important to ask about in patients who may have, for instance, a low certolizumab drug level in the absence of anti-drug antibodies. And finally, we identified a drug threshold of more than 24 micrograms per mil, which may represent an important cutoff for treatment response, and eventually this may help tailor treatments and may help with tapering following well-designed future structured studies.
Well, thank you very much. There's so many interesting aspects of this. The first thing I just like to comment on is that, when Certolizumab Pegol was first introduced into general use and based on in-house immunogenicity, it was actually considered by many to be a drug of low potential immunogenicity because of its pegylation. But as you aptly point out, there's really I don't think there's any way to predict this. And, we can look at drugs such as pegloticase, which is about the most immunogenic drug that we know of, which is highly pegylated. So was this surprising to you or not surprising?
Yeah, indeed, very much was surprising, actually, because as you say, when this drug initially got marketed, it was marketed potentially as a less immunogenic drug. People didn't quite know what pegylation might do to immunogenicity, but it was felt in general it might, in fact, reduce it. There has always been this question of anti-PEG antibodies, but that's not what we're detecting here. And there has been work that's been done by the Netherlands group that actually suggests that the anti-drug antibodies that they detect of certolizumab, more than 97% of them are actually neutralizing. So I think it was certainly an interesting finding and not one that we were initially anticipating.
A second point is that your analysis is quite robust in looking at multiple determinants and disease activity. And at this point in time in the rheumatology world, I don't think that clinicians, even who have access to such assays, have really have incorporated them algorithmically in management. Certainly not like, at least in North America, how the gastroenterologists have used these, extensively. So, if you were, king of the world here, and these drug assays were available in terms of certolizumab, drug levels, and anti-drug antibodies, where do you think that some type of optimal positioning of this might be in management?
So I think that's a really good question, and actually is one that I think people tend to pose quite a lot. And you're right, in the IBD literature, in gastroenterology, even in the UK, people are using anti-drug antibodies and drug levels far more frequently than rheumatology. And I think that's probably because there are fewer therapeutic options in gastroenterology compared to rheumatology. So they need to optimize their drugs much more. I think, I'm not sure how things are like in the US, but in the UK at least, our decision as to which drug we choose for patients actually tends to be dependent on cost. So what sort of our national governing body tells us is the cheapest biologic first, and there's often very little thought.
I said if you were king of the world, you don't have to worry about cost.
Yeah, no, absolutely. So actually, I think what we need, the next step of the puzzle really, is to incorporate this into a randomized controlled trial and see if it actually is beneficial in determining the best available algorithm. Because at the moment, what I was going to say is that there are, whilst we just make our decisions on cost, people have very little thought as to why people have stopped responding to a drug, for instance, and actually having a better understanding of why someone stops responding or the etiology of secondary non-response might help you decide what the next best course of action is, rather than switching them to the next cheapest biologic, for instance. So say if you had a patient who was initially responding very well to the drug and then stopped responding, you check their drug levels and anti-drug antibodies. If they had low drug levels in the absence of anti-drug antibodies, that might prompt the question of adherence in the patient, which I guess one could argue you would do anyway, but it is something that, we routinely don't tend to ask about. And if that is the case, then that's something that you could do to address as a clinician. On the other hand, if the patient had anti-drug antibodies, it might be that the patient has something that potentially might be causing immunogenicity. You may then want to either increase their methotrexate dose or do something in terms of optimization of treatment. Maybe switching them to a less immunogenic drug might be a sensible option. But again, those parts of the algorithm really need to be tested in a randomized controlled trial before we can advocate that to all patients, I think.
The final thing I wanted to ask and comment on is the issue of adherence. And I come to rheumatology through an HIV background, and we live and breathe and die on adherence. I've been always amazed that only in the past couple of years has the word actually been entered into the rheumatologic lexicon, particularly with data on hydroxychloroquine and lupus patients, where everyone was very surprised. How did you determine adherence, and do you have any standards of care in your clinic other than just asking people what they're doing with their drugs?
Yeah, absolutely. That's an excellent question. So in this particular study, you'll know from your own adherence experience, there's no gold standard as to how you capture adherence. And in this study, we captured self-reported adherence, which is, not necessarily perfect. But despite that, we were still able to capture patients who reported to us that they weren't actually taking the drug as prescribed. And in this study and in the previous study that we did on adalimumab and etanercept, adherence seems to come out really strongly as to whether or not the patient has adequate levels of drug. So you can do these fancy tests, but actually if the patients start taking the drug, you can't expect them to respond to the medication as you might expect. So what I would say there is no gold standard, and if anything, this work has just made us prompt us as clinicians to ask the question about adherence in clinic when patients are not responding, which is more than what we used to do. We are actually in the process of developing a local quality improved project to try and improve adherence to both methotrexate and biologics. But that has been a huge work in progress, and we find that there are pockets of patients, for instance, that are much more likely not to be adherent to medications. There are lots of factors at play that we potentially need to address. So to disentangle all of that can be quite tricky. But you're absolutely right. That's something that we are planning on working on initially on a smaller scale in our local departments, and then hopefully upscaling if things work.
Well, in truth-telling, actually, the aspect of adherence was the thing that really caught my eye about your paper. The rest of it is fantastic, but I applaud you for putting this out center stage in rheumatology, and I really encourage you to work in this space. And there's really a lot of lessons to learn from the HIV adherence science base, so I'm sure you're well aware. So anyway, I want to thank you, Meghna, again for a beautiful presentation and congratulate you on your work. And for those of you who have joined us, please come back to Cleveland Clinic eJournal Club again. We're going to be looking at herpes zoster and stroke for our next episode, and tell your friends about our program. Thank you.
That's wonderful. Thanks very much.